So shall we begin? इसमें आगे पीछे के वीडियो भी उसी से वीडियो से Good morning, everyone. Respected faculties, I'm Dr. Vedant Mahachan, Senior Resident Department of Neurosurgery, and I'll be taking you through today's CCR, which we have titled as the Bench at AIIMS to Brilliance in the ORs, a homegrown 5-ALA and IIT Flurescence solution for malignant glioma resection, in collaboration with Department of Ocular Pharmacology, Neuroradiology, Neuropathology, and Department of Biophysics in IIT Delhi. So, talking about the brain cancer disease, high-grade glioma is the worst with a documented median survival of less than a year. And extensive research has been done in the background for high-grade glioma, talking about the parameters to improve survival in patients of high-grade glioma. Subsequently, the concept of extent of resection has come into play. With all the new literature that is focusing upon the extent of resection as a primary parameter for a prognostic indicator, most of the neuro-oncological research has been driven towards achieving the maximum safe resection. And the recent literature has very well stated that gross total resection significantly improves the overall survival of patients in high-grade glioma. It is very well made clear that achieving maximum safe resection is paramount, and even small volumes of resident tumor can lead to an early recurrence. So the basic limitation to achieving this maximum safe resection remains the intraoperative identification of the tumor area, apart from the surgical accessibility and eloquence of the area. Now, many tools have come upon to identify the intra-op tumor, that is intra-op MRI, intra-op USG, and today the tool in focus, that is the fluorescence guided surgery. Current limitations extend into the fact that being from a resource limited country, we have limited resources. And even when the resources are available, the trained surgeons and trained people are still yet to be found. And the most important one is the cost. So while fluorescence guided surgery and 5-ALA has become a standard of care in many Western countries, and its proven ability to maximize EOR is already stated and widespread adoption is clearly done, it is severely hampered because of the major cost that is present here. Also, added to the resource limited settings in our country is the lack of expertise and training in this complex neuro-oncological disease. So the concept of 5-ALA protofiling was introduced, and the following drug goes and is absorbed currently by the high-grade glioma and is converted into protopiperin 9, which in 40 nanometer light releases a fluorescence which is seen in the following images, which we'll see further. The major issue that we have with 5-ALA, when we'll be talking about in detail about this fact, is that the supply chain vulnerabilities. The following drug had to be acquired from foreign countries, had to be taken per patient, permissions had to be taken, and per patient the drug had to be got from foreign countries and picked up from airports per patient. All of the patients had to be credited, the permissions had to be taken per patient, and thus the cost was great, and thus so much of documentation created a long delay in the process. So we'll be talking about this in more detail. To talk about the pharmacokinetics and mechanisms of fluorescence, I'd like to invite the team from. Okay, so we'll be talking about the pharmacokinetics of fluorescence. Basically, it is an oral administered drug, and the absorption happens in the stomach and intestine, and the systemic basically it is fed into the it is taken up by the high-grade glioma cells, and like I've shown before in this image, that it is taken up and it is converted into protopiperin 9. With the 405 nanometer light, it emits a fluorescence which is taken up and which is seen by a device. To talk more in detail about the device, I'd like to call upon my peer from IIT.
So I think Dr. Vail Pandian is organizing a workshop. He's busy there. So this is a slide which has been provided by him. We kept on searching for people who can manufacture the drug in the country. We tried contacting CSIR, ICMR people. I don't know how many places we tried contacting because the drug was very expensive. It is around 1.5 lakh rupees per vial. But fortunately for me, one day I encountered Dr. Vail Pandian somewhere, and I told him this concept. I met Dr. Vail Pandian and I requested him whether we can manufacture it here in AIIMS. And he kindly agreed. He has a very state-of-the-art laboratory here, and we provide him with the molecule. He converts into an oral formulation, and this drug is given to our patients. I unfortunately cannot provide you with the details of it because the patent and everything is pending, and he's the person who knows everything about it. But now the cost for each drug vial that we are administering to the patients from 1.75 lakh rupees has come down to just maybe around 3 to 5,000 rupees. That's it. By virtue of being manufactured here in AIIMS.
So, the question, sir.
The matter is from IIT. He is engineer and professor in the department. And he has helped us develop this device.
Okay, thank you.
And just to give you overview why we have developed this device, because even the microscope which uses the filter, it costs around 40-50,000 euros to buy one filter. So that it is quite superfluous thing you can do with a very good version at a very cheap rate.
Okay, thank you. So, and very happy that you could synthesize this drug here. That is very important. This is we have after this they could succeed developing this synthesizing the drug. But we have to develop a low-cost handheld imaging device for surgical procedure and brain tumor margin detection. You can do that. So this detail I will not go. This is what is a fluorescence. You all know. You can see that the molecule has 3 energy levels here, energy diagrams. Energy. This is the ground state. We call singlet state S1 and S0 as S1 and S2. These are singlet states. This ground state, those closed lines are vibrational and rotational. The molecule, apart from transition from S0 to S1, it also vibrates and rotates. So these are the rotational states. So we have to launch molecule from ground state to the uppermost, at least S1 or S2. And once this molecule absorbs input energy, the basically near ultraviolet A or blue light, and then this molecule goes to higher energy state S1, and then after this quick recession, that is emitting some IR, some vibrational spectra. But from here it comes down, and that energy gap is very large, and then you can basically get this fluorescence. And particularly this 5-ALA drug is having very high quantum efficiency. Normally, most of the drug fluorescent molecules they convert input energy into output light 50% or 60%, but this particular has more than 80% light. And secondly, it emits basically in this red region that is important for. So all in visible spectrum, so it is harmless. The light what we are using is harmless. This is the phenomena of fluorescence. So the fluorescence has become very important for contrast enhancing agent, and particularly I could see that patient is given with orally this drug, and which is not having no side effect. So this is a journey, and where we started doing this first looking at the imported device, how it works, and we did some work here, and after that, and we tried to develop the first version is this one. We tried to do multiple LED of near ultraviolet light, and then that light was not sufficient. That time it could work little bit, and then we changed the strategy. You can see the arrays of LEDs here, the top here, and then of course the amount of light from here to here is given this photograph. And the next version after input from the doctor, this is how we can do translational research by input of from the doctors, and then we came up with a laser based system. So this is a laser based system because laser is having specific light, but you cannot shine laser directly on the human body. We have to do because laser is highly coherent, highly concentrated light. So what we have done is we have basically used this. You cannot. We have used multiple fibers here. So secondly, very high power single laser cannot be used. So that is why we have changed the strategy here. So there are 4 lasers, low power. It has 2 advantages. That is, fiber will not be burned with that light because we are focusing light from inside. And one of the important things happens with the coupling laser with the fiber is a speckle formation, non-uniform illumination. So we have to take care of that, and that was done by inserting a kind of diffuser around here, every one. So this is basically having inside lasers, 4 lasers, coupling lenses, and then a diffuser. Then output light, the entire unit looks like this, is having all independent switches, and we have also had connected with this for NIR laser here. And then along with that, you have a camera inside this tube. That camera gives image on this screen simultaneously, so there is no time lag here. And then that was then second input from Dr. Vivek was that it is bulky, and we need a handheld system. So now the last version we have to do is basically handheld version, which is this. So it is in the small box here, and then it has both light source and with the lens system here. You can see here that there will be this is a camera. Camera is going to your computer or your mobile phone. You can have it in mobile phone a small tab or even PC here, laptop, and then you can switch on button here, and this is equipped with the lens. Lens can focus light or defocus light, and that is how you can change the illumination area. So the final version right now is this one, and then it looks like this. So basically it itself. So we thought of making a battery operated and wireless system, but Dr. Vivek visited us. There was some time lag. He could notice. We could not notice. It is a doctor who can only notice. We thought we have made. Do you remember? You visited that. And we thought it is. There is no time lag now. Our eye could not detect, but he could catch. There is still lag. So we are solving future. So you can expect a completely wireless system, which is having a image, video display, as well as light source. This is what is the next plan, but that is challenge what he mentioned that time. You need to solve the time lag. But at the moment with the wired, both the camera and this cable, the power cable is also there. But we have a battery operated solution now for light source. But only thing is that camera has to be high resolution as well as less than 100 millisecond time lag, and the time lag in our case was around 150, but he could catch, we could not catch, and we thought it is almost real time. So this is what is the important point. So this is how right now this device is having this one, and this is this image. Now we are handing over to the department for this study, and this is, I think it's, does it work? No video working here, no problem. So these are the basically already explained by how what do you do with this is workflow. You already know that, and this I'm not. Now go ahead, please.
So thanks. So as discussed before by Professor VT also, and we'll be talking about the clinical use of this device. We went ahead with performing a non-randomized control study on 30 control and 30 study groups, and went ahead with taking these particular cases, and in the cases we gave the patient 5 ALA diet, that is 3 hours prior to the surgery, and the surgery was carried out in the normal manner using the device, and post-operatively within 48 hours MRI was repeated to see the and whereas in the control group we did not administer the 5 ALA, and surgery was carried out in white light that we usually do. So in the 5 ALA system, we took a detailed consent by the relative and the patient, and following which this dye was given to the patient, that is exactly 3 hours before the procedure. Also during the whole process, there was some chances of photosensitivity. That's why the patient was carried forward to the OT completely covered, and even the OT area was kept dim. So it was said that the intraoperative during the procedure, the OT area was completely kept dim, but over the 60-65 more than that patients that we have operated, we have come to a conclusion that the dimness of the OT can be a little more brighter also, and the side effects were not noted in the situation. So multiple, like Sir said, the multiple different grades and stages of the device was taken up, and that has been showcased. Now I'd like to present one case, that is a 33-year-old female who underwent, who's a recurrent case of left frontal glioma, and this is the pre-op MRI of the patient, and this is a recurrent case, and patient had already received RT-CT. So we used intraoperative neuromonitoring because this tumor was over the motor strip. We used the intraoperative neuromonitoring to locate the tumor, and it showed that it was in the eloquent cortex. See, as you can see, the tumor is getting eliminated in this. So it's not only the fact that we knew the margins of the tumor, but we also knew what was the eloquent area of the tumor, and thus we could do a more guided surgery to preserve the patient's eloquent cortex also. Every time the device was used and noting the areas which had tumor, we proceeded with the resection. This is the post-operative MRI. So what is noteworthy of this is that as soon as the pre-op and post-op MRIs are done, we fused both the MRIs and we calculated the tumor residual which was present, and that way we had an idea for the study and control both what was the residual tumor. Coming to the early clinical outcomes, so the basic demographic parameters that we took for the case and control studies were fairly similar, and we do not have any differences that we noted. Talking about the intraoperative parameters, the operative time which is noteworthy is that using the device did not increase the operative time of the procedure, and the operative time was relatively same. Also talking about the blood loss, we noted in the 30 cases and 30 controls that we operated that the blood loss was relatively lesser in the study group, though the values were not significant yet. The most important one is the extent of resection. What we have noted in the 30 cases that we operated, that there was a significant increase in the GTR rates which were present by using the 5 ALA group, and subtotal resection was reduced to a very minimal number when we were using the 5 ALA, which showed that using the 5 ALA increased the outcomes of gross total resection. That was the main aim for doing the surgery. Talking about the multivariate logistics, we just tried to conclude that no other confounding factors were present, and the 5 ALA was an independent predictor of achieving gross total resection for the patient. We also ran another set of predictive model in which we tried to correlate what were the different surgeons' opinion about using the particular device and how difficult it was for them, and the conclusion was that we did not find any difference. While 5 ALA was used, the Kaplan-Meier showed that the longer follow-up, around 1 to 2 years follow-up was there, and we had a mean survival of the patient for at least 18 months. Now it is to be noted that though the mean survival of the disease itself is very less, but the cases that are operated under AIIMS and the time between the procedure and the radiation and the chemotherapy that is there is also prolonged because of the lack of resources and the sheer burden of patients that we have. Still, we did happen to have a good prognosis of the patients. Talking about the complications of the surgeries, we did not find any difference in the LFTs or hematological parameters. Only one patient presented with minor photosensitivity, and that's what we found, that there was no major complications which were present. To talk about the take-home message and the details, I'd like to mark it in detail.
So these are just the some of the cases that we have operated, and you can see that by virtue of being a tertiary care center, most of the patients have got very large tumors. And when I joined the department in 2007, the saying was that GBM means mortality. That person is not going to survive beyond 6 months of time. And in last 1.5 to 2 years of when we have started operating these patients, we do realize some of them will go on to live longer and without any recurrence. Yes, 11 patients have died, but that's what the disease is like. The only thing that is under the control of a surgeon or a human being at present is how much you can resect and how much you can resect safely. So we have been able to take out very big tumors with very good outcomes. I'm not saying that 5L is the elixir to the immortality or to life and it will not lead to recurrence. But I'm quite sure and pretty sure that what it does is, for a young surgeon, it helps in identifying the tumor, which is very difficult at times for these people. Maybe by virtue of operating thousands of patients myself, it doesn't make a big difference for me, but for them it will make a difference because they can identify this is the tumor margin. Beyond this, we should not go. But for a person who is senior, what is important is even if you see the tumor, you just don't keep on chasing it that you cause a deficit. So the case that he showed you, the tumor was on motor strip. We ended up leaving some part of the tumor so that the patient remains intact. You can go back again if that recurrence is there and still take out. And these are just few cases which have been quite a humbling experience for us, and they show that if you take out the tumor well, the chances of survival are better. In the other arm, there were 30 patients. We are still trying to trace some of these patients. But out of those 30, we have a complete follow-up of 18 patients. And out of those 18, 11 or 12 patients have died. There are few limitations to it. One limitation is that in one arm it is only that me and my colleague Manoj, we have operated. In the other arm there is a bit of heterogeneity, but it goes without saying it's a non-randomized study. But what we have been able to achieve is not just this, but we have found a way to provide safe drug to the patients at a very, very lower cost. The cost is just maybe 5,000 rupees. The drug is safer. It was with great repetition that we thought of giving the drug for the first few patients. We kept the patients in dark, but now we keep the patients in the same ICU. We operate the way we regularly operate, and there are no strict precautions that we take, as we find it to be very safe. And then the device. There have been many, many modifications. Sir has been kind, because from bench to using it on a bedside, there are a lot of problems. There is problem related to sterility, illuminance. Sir provided us with laser lights. They are very sharp, and human eye cannot see beyond a certain range. And when you are operating in a microscope, it has got bright luminance, and suddenly you are operating in dark. Even your pupils take time to adjust. And you as a neurosurgeon are always in a hurry. You don't want to waste your time. So we kept on asking him for better luminance, and then I realized I think it is just because our eyes are not trained to see in blue color, and probably that is why the problem is there. And I hope the newer device which Sir has brought today with himself, it will solve many of the problems, and hopefully we will have better outcomes in patients at a significant cost reduction. And it goes without saying that without finances, you can't do anything. ICMR was very kind to provide with the finances. IIT Delhi and even our pharmacology department, even the neuroradiology department has been very kind. We keep on pushing them to get the MRIs done at the oddest possible hour for the patients. And thanks to all the patients who got themselves recruited willingly. Initially there was trepidation, and then once the word spreads amongst the patients that this patient did well, the next person wants the drug rather than to say no. And these are just the team members, and even the paramedical staff, they play a big role because they are the ones who take care of the patients later on. And with this, I would like to thank Vedant who presented, Dr. Mehta for being here. And if there are any questions for Dr. Mehta, anyone can ask. For me, if you have any questions, I will be happy to answer. I think you can use it for any malignant tumor because what happens is once you give the 5-valent, it goes throughout the body and every cell absorbs it. But the normal cells are able to metabolize it. The malignant cells, it gets stuck and it gets stuck with this protoporphyrin 9. So whatever fluorescence that you are seeing here, it is because of protoporphyrin 9. Because the malignant cells somehow lose the enzyme to process it and it gets accumulated in them. So it's a specific dye. Other dye that is available is fluorescein, but it's very non-specific. It is dependent upon how much vascularity is there. So it will just flow with the blood. If there is high vascularity, you will see it. Once you cut the tumor, it will spread into the abdomen. Then it will be of no use. So I think it might not be a bad idea to use it even in say pancreatic tumors or some GI tumors where you want to see. The dental department, I think, they use it for the microscopy or for looking at the tumors in the mouth. And if I'm not wrong, the skin department also uses it. So there are 2-3 departments who have approached me also whether we can have the dye. And maybe it's not a bad idea to use it because it's safe, at least at till present, and see what happens. You can borrow the device and see in the theatre what happens. You can do that.
I'm Dr. Vallabh, retired professor over here, and I've been with him almost 50 years now. You know, I feel so proud listening. I'm so glad. Today I made an effort on this CCR because whenever I was working, I never used to miss a meeting there, and I'm coming up. And see what a gem I found. And you guys are the vanguard and stuff from IIT. And only yesterday I was making a point with the faculty room that IITs and AIIMS set up a country environment back in the 50s and see today we are seeing the result of that. And Dr. I don't know your name, sorry.
My name is Vivek.
Vivek, and your youngster, you need to be congratulated immensely for this. And I've seen we have lost 3 faculty members to lab, lost them in the last 50 years. I'm sure you're aware of that. And every advance on this tumor is an advance towards humanity. And your team is to do it.
Thank you, sir.
Thank you for the good work. And I'm bringing this to our very proud. Very proud. We did not, what is this? And in the cost down from 1.5 I wish the founders was here to congratulate them and the teamwork. This is the class of people, and this is what we are talking about. This is Bharat here. You guys, never.
Absolutely. I think Dr. Vedant is a separate because Dr. Suri is not here today. So, because whenever you go for a drug trial and you are yourself manufacturing, doing this and that, there are so many clearances and everything is required. And it takes a lot of courage to even say that, okay, I will manufacture the drug. You just go ahead and give it to patient. It's my responsibility. So Dr. Ved Pandey was the one who said, no problem, you go ahead and give it, it's my responsibility.
This is the fruit of patience, persistence, and perseverance. To take every single one. I'm going to write it in my blog or something. And I hope the patients, the word spreading around. So I see people are coming more and more here.
So wherever we go and present, people ask for the drug. Unfortunately, we still cannot provide them because it's part of the research team. We cannot just let others use it. Yes, the names we can do it. If Dr. Chumbar wants, he can take it. That's a different thing altogether. But this thing, whole thing needs to be patented. So I believe that the people they do not.
Should be 30 years ago, the same thing I faced, you know. After all that, I use it for tomorrow tested by the pain. This only problem that I gave up on.
Even people from outside the country, they want to use it because the whole Europe is dependent upon few companies for this. So even they want the drug.
Yeah, मेहनत करो कुछ भी करो. Glioblastoma is one of the dark areas of medicine, and you deserve all. You deserve no prize. Please go ahead, do it fast.
No, no.
Actually, glioblastoma is one of the last frontiers of medical science, where even in the best times, people are dying within 18 months. तो प्लीज गो एक्सपेक्ट अच्छा आप आईआईटी से आपको बिल्कुल खत्म है कि आप करेंगे and one word fantastic vision level to relate to the time that which they do not fit. Yes,
So
that's fantastic. Why? How did you take that small difference?
because see, when we are operating, we are accustomed to operate on endoscopes as well as microscopes. So in microscope, it is the optical light which is entering your eye. So there is no time lag. And our drills, they work at say 1 lakh RPM. Or when we are drilling, it is like this very quick drilling which is happening. So if there is a time lag on the screen, we are able to make out. Even when we are trying to suck out these tumors, we have to do it very quickly at times. If my suction is at this point and I am looking at the screen and it appears here, so there is a time lag that we can make out. So the new CMOS sensors that these companies are manufacturing, whether it is Sony or Nikon and all these people, these are very fast sensors. And now the time lag has been reduced. Similarly, if you want to transmit it to some other hall, until unless you have an optical fiber, there will be a time lag, which will be there. Yeah, so there will always be a time lag because even the screen has a refresh rate. Every screen has a refresh rate. If you remember in old times when there was the black and white TV, so it used to refresh. And if you record it at a very high speed, it will be like this. But new screens they have got very high refresh rate. Therefore, our eyes are not trained or not able to make it out. So you require good quality screen, good quality camera, and a very good quality sensor to have very minimal time lag.
Just clarify one thing. In your group of patients who use the diet, how many have survived more than what's the percentage of people surviving more time compared to the non-group, non-diet?
I think we started in operating in March 2024 and today is November, so around 16-18 months are already there
And people
and 11 people have died, rest of them are survived. Some they do have
that's
recurrence.
almost a 50% increase in survival. Is that
I would call it a 50% increase in survival if you compare it with the Western literature. But if you compare with our own personal cohort, then yes, it's a good and significant number.
Wonderful.